Welcome everyone to this second in a series of Geopolitical Determinants of Health seminar. Welcome to you. Good morning, good evening, good night, wherever you are in the world. I know there's quite a few friends and colleagues joining us. This is the second in a series of seminars we have kindly set up with the Royal Society of Public Health, and this one is sponsored by the World Psychiatric Association. Today we have two outstanding speakers in Professor Dinesh Bugra and Professor Zhao, who will go into much more details into the geopolitical determinants of mental health and those aspects of the global situation that's impacting mental health and psychiatry across the globe. I would like to further introduce Professor Dinesh Bugra, who's one of the architects and founder of this movement, Geopolitical Determinants of Mental Health and Geopsychiatry. And between us, we've been building this movement and building a momentum across the globe. Dinesh has been the past president of the World Psychiatric Association, president of the Royal College of Psychiatrists, and also president of the British Medical Association, amongst the many other positions he held. Books he's written, textbooks, papers, publications, and editors of many journals. So Dinesh, without further ado, I would like to introduce you to begin your presentation on this important topic. Thank you very much.
Thanks very much, Albert, for your leadership and introducing me. It's a great pleasure to be part of the okay, so we're ready to go. Everybody can see my screen. So what I'm going to be talking about is the general principles of what we mean by geopsychiatry and particularly geopolitical determinants. I want to set the scene on a number of things. Firstly, it is what do we mean by geopsychiatry? And then what are the geopolitical determinants? So just to remind ourselves, when we talk about mental health, what do we mean by that? Mental health is absolutely crucial to our well-being. It's about building interpersonal relationships. It's about work relationships within the family, and then at a much larger, broader contribution to community or society. And this is how we cope emotionally. We deal with our thinking, our mood. So there are, when we look at mental illness on the other side of the coin, the mental health and mental illness is, although we use it as a singular, it's not a single term. It's a multiple psychiatric conditions, multiple mental illnesses, which are diagnosable. And I don't want to get into the question of diagnosis here. Perhaps if we have time, we can have a discussion about that. Mental ill health has three prongs in a way: changes in thinking, changes in mood, and changes in behavior. Or some combination thereof, which is associated with individual distress, impaired functioning, and it affects others as well. And when we look at, Michael Marmot's work on social determinants has been quite impressive in the last 10 years or so. He led the WHO Commission on social determinants, which affect everyone in the society. And what the major issue that he raised was that social determinants need to be conceptualized clearly, and then governments, organizations, be they internal, national, academic, clinical, otherwise, need a degree of commitment, and they have to be reasonably competent. So I'm particularly grateful to Royal Society of Public Health for arranging this second in the series. So the aim of social determinants is to reduce the health inequalities, and that occurs across all social gradients. And I want to come back to that because that's an absolutely critical observation. Tragically, A WHO Commission talked about social determinants as a national issue, as a very specific, if you call it local challenges that, rich countries, poor countries, medium income countries, low income countries. But I just want to sort of emphasize that social determinants are not independent. They're influenced by a whole host of international factors. And those international factors are important because no country is an island in that sense that, we all trade with each other, we all move across countries, we all learn from each other. So there's a big interaction that quite often gets forgotten when we're looking at social determinants. So one of the big challenges for us is looking at geopolitical factors. So geographical, political, obviously, I want to come back to the political determinants in a minute, but it's other consequences of geographical factors, whether they are disasters, are they natural, man-made? We know that when Asian tsunami occurred in 2004, thousands of people died. Hundreds of thousands of people were thrown into poverty because they lost their livelihood, they lost their homes, and took a long time to come out of that. And at the same time, a few weeks ago, we heard about the earthquake in Indonesia and what that has done, number of deaths, which also leads to bereavement reactions, grief, as well as survivor guilt. So we need to bear that in mind. And then obviously there are hurricanes and volcanic disruptions and floods and droughts, some of which are man-made and some of which are natural. We know what's happening in Ukraine. Similarly, terrorist attacks, wars, conflict, deforestation, arson, and Zoao will talk a bit more about the impact of deforestation in Brazil and what that means for climate change and the implications it has on people's well-being, mental health, and physical health. So all of these, plus many others, impact on 4 levels. So nations, communities, families, and then individuals. And all of these are likely to lead to internal and external migrations. So people move within the country and the people move out of the country. So we know that geopolitical determinants, whether they're political, commercial, etc., and I want to come back to that, and will impact upon social determinants at national, regional, and local levels. This, to my mind, is one of the most important slides and one of the most important messages that you're going to be able to take with you. Social determinants are influenced by a number of other determinants. Political determinants, we never even think about that. There's been considerable work done in the relationship between countries which have a very purely capitalist model where health can be bought and sold. And then there are socialist countries where there is an equal degree of responsibility and equal challenges. Policies do make a difference. And for a number of reasons, because policies determine where health is sought from, who provides the health, who gives that care, who looks after individuals who may be in distress, stressed, or have a mental disorder. Then we have commercial determinants, and increasingly, no matter where in the world you go, you can find fast food chains, multinational companies who are interested in making money for their shareholders, unhealthy foods, processed food, unhealthy drinks. Now, they affect physical health, which affects mental health. So one of the big challenges for you to take away is that mental health and physical health are not separate. They're linked intimately. So if you're physically unwell, your mental health suffers. If you're mentally unwell, your physical health suffers. We know that from clinical work, and we know that from clinical experience. So we need to be aware of those multiple commercial determinants. And then there are cultural determinants. There was a very interesting study done on WHO data from primary care a few years ago, where Andreas Merker, who's a social psychologist from Geneva, showed that egocentric countries have higher rates of psychiatric disorders. So if you're living in a very individualistic setting, there are high rates of psychiatric disorders, high rates of crime, high rates of divorce. So that in itself, you can think in a very cohesive way as to what that would mean, whereas social-centric countries tend to have lower rates of certain psychiatric disorders, not necessarily all. And those cultural or societal determinants also influence how we define vulnerabilities, whether, physical vulnerability, gender, religion, sexual orientation, how that fits in. And there's considerable research evidence which suggests that LGBTQ plus individuals have higher rates of psychiatric disorders. But when you bring in equality in law, then those rates drop. So to me, that sort of confirms a very clear biopsychosocial model of mental illness, and therefore biopsychosocial model of interventions. And then there are geographical determinants. We know about sort of, regional and national variations. People have talked about something called blue zones, which are the countries where people live much longer, have lower rates of dementia, higher rates of satisfaction, higher rates of happiness. So I want us to look at social determinants as a level below the geopolitical determinants, which are political, commercial, cultural, and geographical. And we know that they affect our health directly and indirectly. So if you're involved in a disaster, you faced an act of terrorism, you're more likely to develop depression and distress. And if somebody in the family has had the same experience, you may be affected indirectly and respond in very different ways. So what tends to happen as a result of these geopolitical determinants? Obviously, as I said earlier, that you get both internal and external migration. And there are political, educational, and economic reasons for migration as well. But geopolitical determinants can lead to poverty, can lead to unemployment, can lead to poor housing, can lead to overcrowding. And then obviously, as I said earlier about the impact of tsunami, you get, bereavement, survivor guilt, trauma, and then a whole host of other potential outcomes. And we know that the latest figures from UNHCR suggest that these are looking at forced displacement. So 80 million people have been forced from their homes due to persecution, conflict, and human rights violations. So 29.6 million refugees, 4.2 million asylum seekers, as well as 45.7 million people who've been displaced internally within a country. Now, refugees and asylum seekers are very legal definitions. They're recognized by the United Nations, and people tend to look at that. And looking at figures from Europe, in spite of COVID, 123,000 people arrived in 2020, which was up 21% since 2019, and highest numbers in Italy. And invasion of Ukraine has contributed further significantly affecting neighboring countries and My understanding is the last count, Poland had more than 1 million Ukrainian people migrating. And so lots of refugees and asylum seekers are fleeing persecution, poverty, and conflicts which go beyond the continent's border. Refugees doubled in 2022 in Europe. Internally displaced people rose to 9 million. And we know, as I said, that the impact of the war in Ukraine and invasion of Ukraine is still to be understood fully and to be seen. So disproportionate burden in Europe, for example, is faced by countries like Greece and Italy. In other countries, Pakistan, for example, so has a very high burden. So low-income countries are facing big challenges. And 2.9 million people have taken refuge from Ukraine as of October 3rd, so about 6 weeks ago. And asylum, as I said, is a legal definition. 67% of refugees and Venezuelans are displaced abroad originated from just 5 countries, according to UNHCR mid-year trends report: Syria, Venezuela, Afghanistan, South Sudan, and Myanmar. And Turkey continues to be hosting the greatest number of refugees. And interestingly, Germany came in 5th place with 1.1 million. So there are legal definitions, there are characteristics, there are motivation, and I'm not going to go through that. But there has been consistent research evidence suggesting that migrants show high rates of psychiatric disorders. There are pressures on services, populations are directly and indirectly affected. And we know that, as we know that migrants are vulnerable, why should that be? And it's been shown considerable solid research evidence which indicates that not only losses happen, but also discrimination in the new country. And perceived discrimination is much more important, and then obviously role of life events. And I don't want to go through that. And we know that climate change, collective violence, famine, floods, and other natural disasters impact upon our mental health, as our chair has already shown. And then we know that there are challenges, as I said, about political determinants, but they can be more complicated in terms of not being able to participate in the new country's processes. And health by itself is political because health is unequally distributed. Health determinants are dependent on political processes, and health is a critical human right. And new countries' responses to various dimensions need to be investigated, particularly to do with discrimination. And then obviously, asylum seekers, refugees may also be facing things like cultural bereavement, culture conflict, culture shock. So we, as clinicians, we need to look out for that. And once people have started settling down, they may give up some of their own behaviors and cultural values. So they become rather shrunk and expand with others, absorbing from the new culture and new society. Lots of evidence suggesting high rates of psychosis in migrant groups has been reported from the UK, Netherlands, Sweden, Israel, even the USA, and Latin American immigration into the USA. There are countrywide differences in rates. So that raises some very interesting questions. Is it simply to do with discrimination? Is it to do with poverty? Is it to do with some other social factors that we don't know? And this is weekly prevalence of depression in the UK, suggesting that Indian women and Pakistani men have higher rates of depression compared to the local population. Similarly, in Latin America, what has been shown is that factors prior to, during, and after migration contribute to the development of depressive symptoms. high levels of poverty contribute to development of depressive symptoms, and then obviously stress and trauma and loss. And there may be some advantage in family reunification, which not surprisingly improves uh, well-being and one's mental state. So having social support, being part of being accepted. And we know that suicidal ideation is higher among um, immigrants. And that was the point that I was making, that Puerto Ricans among Latin American migrants to the USA were more likely to report suicidal ideation. Now, this is quite interesting because technically Puerto Rico is part of the USA. And then we know that how disasters impact upon mental health through damage to property, physical injury, death directly, indirectly within the family, bereavement, psychological distress, displacement of individuals, and prolonged disruption to certain services. And that will affect the victim's ability to operate normally. And how do you deal with loss and poor self-esteem and so on and so forth. And similarly, I mean, the fascinating thing is that people are beginning to talk about climate change, but we have a very long way to go. Climate change can lead to subacute or long-term changes like drought, heat stress, impact of higher temperatures, rising sea levels, and if we have time, our chair can talk a bit about the impact on Caribbean countries of climate change. And we know quite clearly that international terrorism poses a severe short and long-term harm to mental health of people, generating post-traumatic symptoms and so on and so forth. But there's also collective trauma which affects a community which has lost its communality. So there's a much larger social impact on social capital as well as cultural capital of individuals. And it can cause problems in our cognitions, emotional distance, impaired motivation, suspiciousness, can lead to social withdrawal, submissive behavior, can produce lots of sort of psychosomatic symptoms and failure to thrive, and whole list of high levels of various psychiatric disorders. So geopolitical factors, determinants have to be considered upstream, distal determinants, partly because we don't see them directly. We are influenced by social determinants, but for any global institution, it's absolutely vital that they look at much broader picture to see what it does to people's mental health, well-being, physical health, physical well-being. And it, all these impact factors on climate change, migration, natural man-made disorders, there are very clear lessons from the current COVID-19 pandemic. It hasn't gone, it's still there. So we need to be very careful. Let's not be complacent about it. And those multidimensional global challenges need to be addressed quite clearly. And one of the major takeaway messages from this talk is that we need a true international interactions to understand the impact and how things can be stopped. When the Home Secretary in the UK stands up and says the refugees and asylum seekers who are seeking asylum in this country are going to be flown thousands of miles away to Rwanda, what does it does to the people, the country's reputation, and the general sense of communality and belonging. So policymakers have a major role, and psychiatrists need to be advocates, and we need to learn how to advocate for our patients, our services, and acknowledge that there will be cultural variations in coping and managing and rates of psychiatric disorders, and we need to explore those potential explanations. Thank you so much for tuning in and listening. Thanks, Zoao and Albert and Royal Society of Public Health for inviting me. Thank you.
Thank you very much, Dinesh, for that for outstanding presentation that really captures the global scene as it stands today. Just to remind everyone that at the end of November, the world population reached 8 billion people. So it's increasing, and it's increasing unevenly across the globe. I now want to introduce you to Professor Zhao, Professor of Psychiatry at ABC Medical School in Sao Paulo. There's a briefing on him on the script, on the invitation that you've got. But just an update to say that he's recently edited a teamed issue on geopsychiatry, published in the International Review of Psychiatry a couple of months ago. There are 15 papers in that edition, and there's some poignant pieces on what is geopsychiatry. So more details are within that pieces that we've written. So thank you, Zara, for taking the lead in that, and more of that work to come. And without further ado, I want Zara to take over and do his presentation featuring Latin America and the Caribbean. Over to you, Zara.
Thank you, Albert. Thank you, Dinesh, for the invitation. Do you have my screen?
Yes.
Okay. This the chat. Okay. So thank you so much for the invitation, Albert, Dinesh, and the Royal Society. It's a pleasure to be here, and I'm going to add on the presentation. Dinesh made this brilliant introductory talk about geopsychiatry, and Albert asked me to show some data as well, and I found it very interesting to present you data based on the Compassion, Assertive Action, Pragmatism, and Evidence Vulnerability Index, or just CAPE Index, that was created by Albert and other colleagues, and we are using this index to produce some data. So geopsychiatry, what is geopsychiatry? And this is our editorial in this themed issue. I invite you to read it, but it's a development field in which we have studies the interface between geography and psychiatry. The main focuses are on climate change, disasters, globalization, population growth, movements, urban agglomerations, agricultural production, industrialization, geopolitics, socioeconomic transformation, and also cultural practices. It's a very intersectoral field that can involve professionals from different areas, such as geographers, physicians, economists, politicians, agronomists, social workers, among others. And it's interesting because geopsychiatry is strongly in line with the biopsychosocial model for health and illness, and can help to plan how to detect and to deliver healthcare through biological, psychological, and social aspects of their complex relationships, and so it's obviously that we are not the solely or the only discipline in the field. We work closely with other disciplines and in fields like public health, medical anthropology, social psychiatry, medical geography, cultural psychiatry, among others. So, but our topics are very important in the way that we can examine the causal chain for mental disorders, and we can investigate the geographic risk factors and for mental and substance use disorders, but also the protective geographical and environmental factors for mental disorders. So it's a very interesting field. So CAPE Index is a global index that highlights the need for assistance in countries with a high degree of vulnerability. It is composed by 9 items, and I'm going to talk a bit about these items here. You probably know, but it's important just to give you a taste of what is CAPE. But life expectancy at birth. So we extract this data from WHO database. Disability adjusted life years, which also named as DALIS. We extract this data from the Global Burden of Disease study that was developed by Institute of Health Metrics in Seattle. And DALIS is the unit that is the sum of years of life lost and years lived with disability. Physicians per person that we source from World Bank. It's also the number of physicians per 1,000 people. GDP that we source from International Monetary Fund. The Gini coefficient, which is a very interesting coefficient, used to measure income inequality, is a good indicator of relative wealth rather than absolute wealth. And it is derived from individual and household income data. We also gather data on current conflicts from multiple lists, ongoing armed conflicts and the death toll associated with these conflicts. The number of refugees is sourced by the country of origin, obviously from the World Bank. The Corruption Perceptions Index, the CPI, a very interesting index from the Transparency International. It's a ranking system based on perceived levels of the public sector corruption as judged by experts and also opinion surveys in the countries. And last, the external aid received, which is we source it from the Organization for Economic Cooperation and Development. If we look at the literature, we will easily find that each of these 9 items are associated with incidence and prevalence of mental disorder. As an example, we have high mortality rates among people living with mental disorders, both because of the comorbidity with medical diseases and also because of the mortality associated with the mental disorders itself because of injuries, for example. The DALIS has been largely associated with mental disorder. The DALIS due to mental disorders has been largely increasing in the last decades. Political and civil conflicts, as Dinesh said in the first talk, it's hugely associated with mental disorders. And a lot of people displaced that we have, the traumatic experience that we have, and even after years of resettlement, these people will have a higher prevalence of mental disorders than the general population. So saying that, we collected data from 193 countries, 47 from Africa, 35 from Americas, 53 from Europe, 27 from Western Pacific, 11 from Southeast Asia, and 21 from Eastern Mediterranean. We extracted values for CAPE index. We didn't have data from part of the country, so we just had data from 137 countries. And CAPE, the scores that CAPE produce, how do we get the score, the CAPE score? We evaluate if the country is in the ranking for each of the CAPE item, each of the 9 of the CAPE items. We evaluate if the country is in the top 20. If the country is in the top 20, there is a 1 point for this country. So the maximum score is 9 and the lowest is 0. So here we we have in this figure the most vulnerable countries. We have the 23 countries with more than a score above 3. We have 4 countries from Latin America: Honduras, Colombia, Haiti, and Guatemala. 1 in Southeast Asia, Myanmar. 1 in Middle East, which is Iraq, and also 1 in Eastern Europe, that is Azerbaijan. The rest, the 16 other countries, are located in Africa, and we have Central African Republic, Mali, Ethiopia, Cameroon, Sudan, Guinea, Zambia, Mozambique, Lesotho, Nigeria, Rwanda, Niger, Burkina Faso, Chad, Benin, and Côte d'Ivoire. And obviously that we don't, as I said, we didn't have data from all the countries, but the lack of data was more related to the size of the country than the level of development, we can say. So you can see here's countries with very low income countries, and we had data from this country. So we believe that there is a good global picture in this report. And here we have the average of mental health disorders in these countries, in the most vulnerable. So we have the highest prevalence was found in Sudan, with 16%. For mental disorders, and the highest substance use disorder prevalence was found in Guatemala with 3.6. These are good examples for further discussion. If we look here, we use it. CAPE is not a good index for evaluating wealthness. He's a good index for evaluating vulnerability. And so we used the quality of life index to see the opposite, to see the most wealth countries, and we selected the 23. And you can see here that we have, in truth, higher rates of mental disorders of 15% and 3.5 compared to 12.5 and 1.7. And so we wanted to use CAPE to present and discuss the role of global vulnerability for mental disorders. And we were especially interested in how CAPE was correlated with the prevalence of mental disorders. And we found that just the opposite, just a lower prevalence in the highly vulnerable countries. Despite of the discussion about egocentric and non-egocentric culture, we found that there is a urgent need for detection of mental disorders in these countries. There is a lack of data in these countries, and this is something that will rely on other factors. But there is also poor knowledge on mental health disorders, lower mental health literacy among the health professionals, and also the population itself. We have increased levels of stigma related and attached to mental disorders, and a lack of mental health services, which are the main source of mental health prevalence data for a global burden of diseases, which is the source that we use it for the prevalence data. So it's there is a lot of space for improvement in mental health data systems. It's interesting to see that the rate of psychiatrists there is a huge disparity. We have 28 psychiatrists per 100,000 individuals in New Zealand, for example, and 11 in the US, compared to 0.1 in Sudan and 0.5 in Guatemala. So if we look at the table and if we compare this 16% of prevalence in Sudan with New Zealand with 19, I really believe that and I think that's if we have at least a more reasonable rate of psychiatrists, we will really have a higher rate of mental disorders. Same thing for Guatemala compared to US in the substance use scenario, in which we have a 3.6 for Guatemala compared to 6 in US, and however we have a huge difference. CAPE could be useful, and we present CAPE in terms of a good tool for detecting the most vulnerable countries and those which should receive external aid for mental disorder detection services and all things involving mental disorders. Because when we stratify the countries in a more whole way, for example, here in the social demographic index, which is an index developed by the Global Burden of Disease study, you will see that there is not so much difference among the high income, middle income, low middle, and low level of SDI countries. So CAPE could be a bit more specific in detect the most vulnerable countries. And so we believe that there is a huge gap for increasing in mental health literacy, especially among health professionals, non-mental health, but general health professionals. We believe that there will not be a huge increase in mental health professionals in these most vulnerable countries. So it's really important to prepare the general professionals for that, and also to bet on task sharing and task shifting, promoting and educating other professionals like WHO do with the MH Gap project, in which they share the mental health task with other professionals, and even with non-professionals that don't have the degree, non-health degree professionals like the community health workers that are very important in low and middle income countries. So increasing their mental health literacy can improve a lot the chances of someone with depression or any other mental disorders to be screened and detected in the community. So there is a lot of gap and space for research on how can we implement and intervene with these communities with very low levels of resources for mental health. And CAPE could be a very good tool to develop action plans for these countries, these most vulnerable countries. Oh, this is my email, and I will be very happy to discuss any topic or comment.
Thank you very much, Zhao. That was a wonderful presentation articulating how CAPE was developed and its value, in Latin America and in the Caribbean. Safe to say you guys are working on a second edition of the CAPE, and more on that will come true. I think Dr. Jibril is on this conference call here, and he's looking to develop something similar for Africa. And what's emerging is that more regions are trying to develop their own specific CAPE vulnerability index for their area. So thank you very much for that. There is a series of questions that's cropping up on the chat. Yes, I'm not sure. So I think there's 9 or 10 that's already arrived. So if people on this call can I keep adding your questions on, we'll try and answer as many as possible. But one of the key features that I see that's emerging is around geopsychiatry scholarship, PhD programs, fellowship, and locking geopsychiatry into educational program with a college and other professionals and things like that. So Dinesh, do you want to take the first set of questions from what you can see? Can you see the questions?
Yes, thank you. Firstly, there's a question about scholarships and geopsychiatry, and I think one of the big challenges really is that we need to create a movement of people who are interested in the field, and then look at the implications and look at the, and then look at the funding and look at setting up scholarships and PhDs and so on and so forth. But it's also really vital that, no matter where you are, bear the geopolitical determinants in mind when you're seeing your patients and when you're trying to advocate for services and development and talking to policymakers, particularly politicians. One thing that is absolutely vital when you're talking to politicians is you need to remind them what they want their legacy to be. Politicians have a very short attention span. They're just looking 18 months, 2 years maximum before the next election. So the challenge to them is, what do you want to be remembered for? And it would be an awareness of geopolitical determinants. And we've seen the climate change has suddenly become a major focus for many countries, and particularly, countries like Barbados and, Mauritius and Seychelles. And, if the sea levels continue to rise, the countries would disappear. So using that kind of data and what Zoao has already presented, having access to that information and then going to the stakeholders and say, we need to do something. It's not their problem. It's not our problem. It's everybody's problem. We need to do it jointly. The second question that was raised was about commercial determinants of health. And there was an argument whether it should be ill health or health. I think it is absolutely critical that whatever term we use, we are aware of the implications. Fast food, processed food, fizzy drinks have a major challenge on people's health and well-being. And if you, as a result of those, you develop diabetes, you develop hypertension, you're more likely to get depression. So it is really ridiculous to say that I can only treat obesity, but not depression. So part of the challenge is bringing mental health and physical health closer together, which happens in lots of countries. It's only in the developed countries, high-income countries, that there is a very clear distinction. In many low-income countries, doctors do everything, and they can bring things together. So that dichotomy, to my mind, is a completely artificial one. Commercial determinants affect health, which includes mental health. They can produce diabetes, they can produce hypertension, they can produce obesity, they can produce a whole host of other problems that we don't even know of with all the chemicals which have been added to the food. So the point that I really want to drive home is that social determinants should not be seen in isolation. They are influenced by a whole host of other factors. We've only now started hearing about cultural determinants, that egocentric countries have higher rates of psychiatric disorders. Now, that may be true, it may not be true, but it may also be that we are using Western tools to measure psychiatric disorders in low-income countries. And we are using same kind of treatments, which may or may not work. So we need to be very cautious of cultural determinants, cultural relativism, and then create services that people would use. And that has similar implications for public health. Public mental health is part of public health. And in many countries, there is social and preventive medicine. But there's no emphasis on mental health, but it's much more to do with vaccination and nutrition and clean water, all very important. But equally important is, how do we use that access to social medicine to bring the agenda on mental health upwards and forwards?
Yeah, thank you for that. I think COVID and the climate crisis have really exposed the global scenario.
Disparities, yeah.
Yes, because geopolitical factors, for example, I mean, you will know this better now, but the removal of the rainforest and deforestation, and what's having in those communities who live there, and everything else. That is worrisome globally, and I hope that organizations like the World Bank and the bigger psychiatric community can really come together to look at how we support these communities, and do that. And I'm glad to see that CAPE is being developed to enhance that and move that forward. There's a question there about getting it into the education curriculum. On this chat, on this conference, there's a wide cross-section of disciplines, a wide cross-section of people representing various institutions and organizations. How can something like this develop into the curriculum? I mean, social determinants is well embedded. There isn't a conference you go to that people mention social determinants. How do we get this into the curriculum? Where do we start? Zhao?
Yeah, I was thinking about that because at least in Brazil, and the curricula of the psychiatry residents or the medical students are heavily focused on the biological factors and also in psychopathology itself for psychiatric residents, and it's really important to give much more attention to social determinants and geopolitical determinants and how this affects the patients that you are seeing in your region. Because I can remember in Brazil, we have a good example of someone who worked in close to the tobacco growing areas. And most of the patients that they seen was people that were involved in tobacco production in these places. And in these places, the rates of unemployment were increasing. And most of these people smoked, for example, and they have to, if you do not consider these factors in your practice, it's very difficult to understand what is happening and why in this region we have very high rates of nicotine dependence and why people more depressed. So in my view, I think we should include much more learning on social aspects and also in how the geopolitical determinants affect people in your region, because this comes to the health professional practice.
Yeah, I mean, the UK, we have an energy crisis, partly driven by the war in Ukraine. Previously, housing comes under the social determinants factor. What's happening in the UK with prices and access to heating and, those sort of stuff that we've taken for granted. Geopolitical factors are shaping that, because what's happening in Ukraine is affecting the world, but affecting, the G7. The food chain has been interrupted because we cannot get out to supply around the world, exacerbating hunger. And some of the poorest is more affected. They're affected by climate change, they're affected by COVID, lack of vaccine, food scarcity, and everything. It's the same community. Dinesh, have you got a thought on that in terms of, where do we position geopolitical determinants of health within the G7 countries, the rich countries who seems to think, everything happens elsewhere?
There are several strands to what we need to do. I mean, particularly, webinars like this raise awareness. All the participants can then go back to their institutions and say, hey, I've heard this, and can we do something about it? The fact that people are looking at the possibility of doing PhDs. But equally importantly, I think if I had the power and I was setting up the curriculum in medical schools, I would start teaching psychiatry from day one, not in year 4. And I would emphasize the biopsychosocial models. Medicine itself is biopsychosocial. And just to argue that it's simply biological doesn't work. So you can have a perfectly correct hip replacement, but you can't walk, you can't go to your job, you can't go shopping. What's the point? So, message to everyone tuned in is that health is everybody's business. Health education is everybody's business, whether we do it on the community level or in a medical school or in a postgraduate institution or a university or globally. We need to keep saying that, countries are not isolated, they're linked with each other, and geopolitical factors in one country will have a domino effect on others. So we need an innovative way of looking at health. We need a different way of describing, defining, and delivering healthcare in that particular context.
Okay, there's a question in the question section. Can you see that? Let me see what it says. Thank you for the webinar. Sorry to leave. Someone is leaving, so that's come up. Do you have access to the audio? Okay, if you don't click, never mind. What I was going to say is that one of the things we can start from today is that if people, when they go back, you mentioned it, Dinesh, if people go back to the job or their places of work, you can begin to start discussion around geopolitical determinants of health and geopsychiatry. Form little groups and let us hear of it, because we're hoping to be in force at the WPA Congress in Vienna next year. And we hope we'll have some symposium there, and you can join us and let us know in the meantime what you're doing. So we'll be there in force. All three of us, I chair the WPA with Zhao, the WPA group on geopsychiatry. And in the next few months, we're in a position we'll be producing 2 policy documents for psychiatry, mental health, that crosses over these aspects that Dinesh so carefully articulated earlier on climate change and migration, because that's another area we haven't covered as yet. So we're hoping to do that and have a big event. I think we also got a couple of textbook on the line as well. So more will emerge. I'm conscious of the time that I have to go, and we have to go soon. You've got the emails being distributed there. All of our emails are available from Royal Society of Public Health, and you can get in contact with us and hear more. There's another question up, if I can get that in quickly to you guys. Can you see the question? Thank you for the webinar. I can't see anything else. Okay. Victoria.
Yeah, Thelma, the correct email is the second. Thelma asked me to share my email is the second, not the first one.
Okay.
And I would like to thank you as well, Albert. Thank you so much for the opportunity and for inviting me to work on this very interesting field. And we didn't have time to talk about deforestation, that perhaps in the next webinar we were talking about specific cases, but okay, and that's it. Thank you so much. Very good.
I want to thank the Royal Society of Public Health, who is a major contributor to this program. They're the pillar to the in the UK and globally, and leading in the COVID vaccine and education programs, and do some wonderful work. So do join up and join the newsletter. They have a publication. And the World Psychiatric Association, Dinesh was past president, and Afzal for this. And more will come. We're looking at our 3rd series of our presentation, and hopefully we will present that much more on migration, displacement, gender, and that specific theme. So I think our time is up. 2:01. We haven't got much more time. Dinesh, were you going to say something finally?
No, thank you very much.
Okay. So thank you all for participating. This will be turned into a YouTube event, and we'll add more questions in. You have an email. Do join us, join this movement, and do have a wonderful day, evening, nighttime, wherever you are, and do join us. So thank you very much. Take care.